The special test being examined will be the upper limb tension test 1 for identifying carpal tunnel syndrome. The plan of attack will be to describe the technique, go over the positive signs diagnosing carpal tunnel syndrome, then there will be a demonstration video. Next, we'll go over psychometric properties from 3 different articles. We'll go over comparisons to other tests, and then there will be a quick summary and time to practice. To begin the technique, the patient will start in the bunny position. The therapist will then passively perform scapular depression, shoulder abduction to 90 to 110 degrees, forearm supination, wrist and finger extension, shoulder external rotation, elbow extension, and the therapist will hold that position while the patient side bends the neck contralaterally and then ipsilaterally. And next, the therapist will perform the same technique on the painful side. The test is positive for carpal tunnel syndrome if symptoms including pain or numbness in the wrist or fingers is reproduced, if there is greater than 10 degrees side-to-side difference in elbow extension, or if contralateral neck side bending increases the symptoms and then ipsilateral neck side bending decreases the symptoms. Here we have the upper limb tension test 1 for identifying carpal tunnel syndrome. So first you want to have the patient start in the bunny position. Okay. And then as the therapist, you want to depress the shoulder, abduct it 90 to 110 degrees, supinate the forearm, extend the fingers and the wrist, externally rotate the shoulder, and then extend the elbow. And then you want to have the patient bend their neck to the opposite side. So Jeff, can I have you bend your neck to the left? Do you have any pain with that?
No.
No pain, okay. And now bend your neck towards me. Do you have any pain with that?
No.
No pain, okay. So first you want to test them on the uninvolved arm, and then we're going to go ahead and test them on the painful side. Okay, so here we are with the painful arm. So Jeff, start in the bunny position. We're going to do the same thing. Press the shoulder, abduct the arm 90 to 110 degrees, supinate the wrist, supinate the forearm, extend the wrist and fingers, externally rotate the shoulder, extend the elbow, and now Jeff, bend your neck to the right side. Do you have pain with this?
Yes.
Yes, you do have pain, okay.
Deep pain.
Now bend your neck towards me. What does that do to your pain?
It lessened up.
Less pain? Nice. Okay. It's a positive test for carpal tunnel syndrome. In the first article, Weiner 2005, the population studied included 82 patients with suspected cervical radiculopathy or carpal tunnel syndrome. The inter-rater reliability of the test was 0.76, which demonstrates moderate agreement in results between different testers. The sensitivity of the test was 0.75. A high sensitivity means that the most subjects who did test positive on the ULTT were truly positive based on the gold standard of diagnosing carpal tunnel syndrome. The specificity of the test was 0.13. A low specificity means that the ULTT did not produce a negative result with most patients who were identified to be normal as tested by the gold standard. The positive likelihood ratio indicates the people who tested positive that have been diagnosed with carpal tunnel syndrome. In this case, you want a number greater than 10 for strong evidence. The PLR of the ULTT was a 0.86. A PLR less than 1.0 demonstrates rarely important degree of probability that the ULTT is actually indicative of carpal tunnel syndrome. The negative likelihood ratio indicates people who tested negative that do not have the condition. In this case, you want a number less than 0.1 for strong evidence. In this study, the NLR was a 1.9. An NLR above 1 demonstrates a rarely important degree of probability that a negative test will indicate that the subject does not have carpal tunnel syndrome. The second article by Talibi 2012 used a patient population of 23 normal subjects and 12 diagnosed with carpal tunnel syndrome. The study resulted in an inter-rater reliability of 0.89 for healthy subjects and 0.85 for subjects with carpal tunnel syndrome. Both stats determine that the ULTT is highly reproducible between multiple tests by the same tester. In the last article by Vanti 2011, the population studied included 47 subjects with suspected carpal tunnel syndrome. There was a high specificity and a low sensitivity, similar to the Weiner article. The positive likelihood ratio of 1.08 also demonstrates a rarely important degree of probability that a positive ULTT is actually indicative of CTS. The negative likelihood ratio of 0.56 demonstrates a rarely important degree of probability that a negative test will indicate that the subject does not have CTS, also similar to the Weiner article. The ULTT2 was also created to examine the median nerve. The Weiner article demonstrated that the ULTT2 also does not have great validity in identifying carpal tunnel syndrome, while in another research study by Sandmark et al., ULTT1 has been demonstrated to have significant validity as far as a high specificity and high sensitivity in identifying cervical radiculopathy. ULTT1 and ULTT2 were both created to lengthen and test the median nerve specifically. More research needs to be reviewed to determine which test is best for identifying CTS, and also if either test is better in identifying cervical radiculopathy rather than carpal tunnel syndrome. In conclusion, the ULTT1 is a highly reliable test. However, the validity of the test for identifying carpal tunnel syndrome is not strong. Clinically, it is important to investigate other special tests, clinical prediction rules, or diagnostic tests to use in conjunction when ruling CTS in or out.